We are also publishing the third newsletter of MCNS during this. At the end of the seminar, Dr. Sudhir Ambekar, who is doing an excellent work, will introduce this. As a logical conclusion to our newsletter, we are planning to start our own MCNS journal. So through this, I'll also inform you on our WhatsApp site as well as personal emails. And I would urge all the members to contribute actively towards this so that we'll be able to make this a great success. So with this, I'll request Dr. Muzumdar to take over and start today's proceedings. Dr. Muzumdar.
Yeah. Thank you, Dr. Katikar. And it's my pleasure to moderate the webinar number 8 on a very important topic of complication or avoidance in CSF diversion, I would say, hydrocephalus. So we have a great lineup of speakers. Dr. Suhas Udaykumaran from Kochi, Dr. Ashish Chut from Privavati, Pune, and Dr. Naresh Biyani from Wadia Hospital, Mumbai. So with this, I would request all the participants, if they have any comments, they can put it in the chat box, which I will take the questions with the speakers. And at the end of Dr. Debujari, should we take the questions at the end of all 3 talks or after each talk? That is there. So maybe we'll decide if there are some pressing questions, we'll take them after the talk, or we can have during the panel discussion for 10 to 15 minutes. We can have all 3 speakers. After the panelist comments, we'll have the speakers giving their own rebuttals. So without any delay, I would ask Dr. Suhas Udaykumaran. He is the professor of pediatric neurosurgery at the famed Amrita Institute of Medical Sciences, Kochi, and he's also the secretary of the Indian Society of Pediatric Neurosurgery. He is one of the foremost proponents of pediatric neurosurgery in the country today, and his practice is dedicated to pediatric neurosurgery. He has got great work in craniofacial deformities, which is known all over. And he has also published in Neurology India a seminal paper on shunt infections. So, Dr. Suhas, can you start your talk, please?
Yeah. Thank you, sir.
Yeah.
My audio is clear, isn't it, sir?
Yes, audio is clear. Yeah.
Yeah. So at the outset, good evening to all the members of MCNS, and my sincere thanks to Dr. Majumdar, my teacher, and all the seniors on MCS, Dr. Depujari, Dr. Sankla, I can see them. Good evening to all of everybody. So I'll start off with we all realize that it's such a complicated topic, shunt complications in VP, shunt complications secondary to VP shunts in after hydrocephalus surgery. So if I start listing the complications, the list is overwhelming with all the possibilities and probabilities that we know since we have included this as a treatment modality into our specialty and as individually. And to look at it together, it's a highly stigmatized surgery.
But what's the background behind this graphic?
But at
the wall.
There's some voice disturbance.
Is there a voice disturbance? Shubham, can you check the voice disturbance in the background?
So
yes,
yeah. So essentially, it's a highly stigmatized surgery, but at the same time, a very life-saving surgery. And we need to be very clear about what causes all these complications and how to avoid them to the best interest of all the patients which we treat. So as I started off with, this is one of the medical devices which is implanted in modern medical practice with the highest failure rate, with let's say about 70% in a total of 10 years. With about 50% in first 2 years, and but at the same time, we realize that complications in shunt surgery is a highly predictable and has a very patterned way. So why are shunt complications prone? So I'm going to look at the shunt complications not just as a list, but trying to understand it in a different perspective, so that probably we can improve on what is improvable rather than looking just as a complication which will just come and go. So are they really complication prone? So if you look at the surgeries that are done for VP shunt, I mean, as a VP shunt, we treat a spectrum of, we treat from prematures to elderly. So that's one obvious reason. We have a spectrum of age that where we use VP shunt. We try to simulate a physiology which is highly complex and a very complex human physiology. And then there's the technology which is inherent with its own failures. And of course, another important aspect which makes it prone to complications or so-called adds to the list of complications is the fact that it is a long-term implant with a long timeline and staying around for lifelong in most patients. So let's try to deconstruct the shunt complications. So of course, if you look at the physiology by itself, it's highest in the neonates because of obvious reasons, and then followed by the youngest ones, and then the older adults. And then if you look at other possibilities of why the shunt complications happen, one is it involves a very complicated flow dynamics involving CSF in a finely graduated and in a tubular way. And then there's an additional aspect of infection and inflammation, mostly in the youngest ones. And then, of course, the material-related issues. And if you look at the timeline of the complications might occur at different timelines. One is at the level of decision-making, then the level of planning, then at the intraoperative stage, and immediate post-operative, and then, of course, at the follow-up. My idea of looking at it in all these perspectives is to cut down the complications at each of these junctures. So if you look at the decision-making stage, we realize that a right decision can always go a long way. So in decision lies the key. So if you look at the first decision which we make when we decide for a shunt is whether we need to treat a situation or not. So are we dealing with ventriculomegaly or a true progressive hydrocephalus? So that is the first question we are supposed to ask ourselves when we treat any hydrocephalus, and this more so in the youngest ones, or even the older ones, of course, but primarily youngest ones, because once the brunt is done, you cannot revert back. Then you realize whether you want this as a permanent procedure or you can avert it with a temporizing situation. Then you ask yourself whether the same shunt can be substituted by endoscopic third ventriculostomy, which does not have implant, or can you do a definitive surgery? Let's say example might be a third ventricular arachnoid cyst, where you can do a shunt, you can do a endoscopic third ventriculostomy or endoscopic fenestration, and the definitive surgery in open hospitalization. Then you have situations where you have, let's say, posterior fossa tumor, where you can use shunt at the first instance, but at the same time, maybe you can avoid it by definitive surgery. So then it comes in the decision making, the choices of implants, which can create havoc during the follow-ups, and which will add up to the complications. Then in the same decision making, another important aspect is how you time the decision, at what time you want to do the decision. For example, if you look at pediatric neurosurgery, when we have prematures, we try to avoid a permanent implant at the beginning, try to temporize it with multiple options, including ventricular subgaleal shunt, etc., etc. And then we wait for the babies to get older, gain adequate weight, and then proceed with a complicated shunt, or even try to avoid that shunt. And then you want to look at the CSF picture, the first instance, before you put a VP shunt. You have to rule out, we always try to rule out an infective situation or an infectant which is receding. And then, of course, the question of is the protein high to cause further malfunctions once you insert a VP shunt? Of course, by recommendation, we do not consider protein as a contraindication, but we still keep it an arbitrary mark of about 200 plus to avoid a shunt multiple malfunctions secondary to the protein level. So the next so after the decision making is done, the next important step is planning a shunt. So this is where the second set of complications come in. So when you look at the planning, identifying the risk factors at the level of planning stage is very important to identify the key complications. So prematurity is obviously one of the most key and important risk factors when it comes to the youngest ones. because of the weight, immunocompromised state, etc., etc. Then, of course, the children. Then the nutrition and immunosuppressed state, probably hygiene. Then having a post hemorrhagic state, having a neoplasm in situ, and then doing a shunt on it. Having a post-infective status or immediate post-infective status, having an abnormal anatomy, having a subsmall ventricles, having very large ventricles, having a very thin mantle. All these adds to risk factors at the stage of planning. So I have not elaborated of each of them, but it's very obvious that each of them can have multiple complications, which we are well aware of. So at this stage, we try to identify how to proceed by looking at the risk factors where we can and cutting down the possible complications or anticipating complications at this stage. And again, this was a part of our article which came up in Neurology India. So there is insufficient evidence to recommend a particular CSF parameter to direct the timing and timing of shunt placement in any age group. And then there's insufficient evidence to recommend a particular infant age and weight when the shunt can be placed. And again, etiology specific timing is also not clear. So all these evidence are of very low certainty, but at the same time, key in decision making. When you start the planning, you always it has been a regular culture of the shunt being done by the youngest ones, youngest trainees or as the residents or the youngest in the team. But at the same time, there's enough of evidence that higher the experience, the lesser the complications. And this is although this is applicable to most field, in shunt too, it's equally true. And this has been well supported in multiple papers. So in the Indian society guidelines, we put it as at least the high-risk population of the prematures and the youngest ones should be done by at least experienced surgeons, pediatric neurosurgeons, or under their supervision, and probably in a high volume center. So this has a moderate certainty level of evidence. So if you look at the avoiding the complications. So in the interop situations, you need to decide what valve to use, what kind of implant you want to use, how do you want to conduct the surgery, and how do you want to navigate the ventricles, etc. So these are the interop key steps. Of course, there are multiple steps, but these are the key steps that are complication-ridden. So as I mentioned, the flow dynamics are very important to be understood when we choose the valves. So when you come to the valves, there are three important questions that we deal with while we choose the valves. One is, of course, the standard question of whether to use the programmable versus flow control valves, and then the newer set of valves. And then, are you anticipating under drainage or over drainage? And if it's infant, what should be the first valve? These are the common questions which are specifically related to the valves. This is the Cochrane Library recent review in 2020, which says that the programmable valve versus flow control valves do not have any much difference. Programmable versus valves with anti-siphon device versus standard flow control valves do not have any difference in outcome. So this is the standard of care as of now, at least on literature. But there are recent papers coming up where gravitation assisted valves, or GAVs, programmable and non-programmable, both are considered useful in the youngest ones, and as they grow, they might require upgradation into higher one with higher opening pressure. So we see different situations. This might be benign situation where you have just have over drainage immediately after a shunt in a closed calvarium, and then sometimes you have hemorrhages. So you have over drainage and under drainage too. So most of the shunt issues are because it has a very sophisticated mechanism, and the CSF flow is very complex. So the next important question, apart from these two, are which valve should be used, which should be the first valve in the youngest ones, especially the prematures and the infants. So there are multiple works on the same lines, but there are no clear answers on what valve should be the first valve. At least one of these papers mentions programmable valves still can be used in prematures. The smallest valve which can be used in prematures might be the Codman microvalves. So there is no appropriate shunt for the youngest ones. But in my practice, I use the low pressure and upgrade to programmable as they grow. This may or may not be the right way to do, but that's my practice. Now, this was an interesting statement which I found at one of the older papers, which says that every shunt is an ideal shunt, provided the choice of shunt is made according to matching the performance of the shunt system, the altered profile of the CSF dynamics of the given patient. The most important factor being the opening pressure. The next important, so as I mentioned, these are a part of the intra-op decision making, the valves. After the valve comes the standard protocol which you would use. The use, it's very clear that the use and adherence to standardized shunt surgery protocols are reduce shunt infection rates. So this was the protocol which we proposed in the Indian Society guidelines paper. And this is not our singular opinion. This is an opinion which is carried out over time and has been practiced by most pediatric neurosurgeons and people who are serious in shunt complications and their outcome. So the body wash with chlorhexidine at least 48 hours before surgery, avoiding infective. You have already seen to it that you have avoided infective foci. Preoperative antibiotics at least 30. If you know the antibiogram of your hospital, use that specifically, or it's a third generation, second or third generation cephalosporins with gram-positive coverage, vancomycin indicated where MRS is known, and in half an hour before induction of anesthesia. Then a common scrub of chlorhexidine, betadine, and soap. This is what we proposed. Hand wash according to standard hand wash techniques, double gloving, use of IDO4, although it does not have support, but it's a part of this protocol bundle. And then it should be no touch technique with the rooms being closed. Change of gloves before touching the implant, and use of intrathecal vancomycin during insertion of the ventricular catheter, and antibiotic impregnated antibiotic sutures. These have great class one evidence. These have recent class 1 evidence. I'll allude to it in the next slide. But antibiotic impregnated shunts and antimicrobial sutures have class 1 evidence, although there are very few papers on it. And a meticulous closure and wound dressing. So as I mentioned, antibiotic prophylaxis is one of the key steps probably of adding to avoiding a shunt complication secondary to infection, and this has a moderate evidence of certainty. But at the same time, I would like to remind that it should be within half an hour to 120 minutes if it's vancomycin, of course, and we should be stopped by 24 hours within 24 hours, not more than that. And use of antibiotic impregnated shunts in avoiding shunt infections has come up as a very strong paper in this one particular work, which is the class 2 evidence and an RCT. The second important aspect of during intra-op is how to avoid obstructive complications at all levels of shunt, that is proximal valve and distal. So in that, we look at the ventricular entry, and it's clear that no particular ventricular entry has been proven to be superior in terms of avoiding proximal obstruction. But still, we still use frontal entries in children, at least, for who have very large heads, to avoid dependence pressure on the valve, etc. when you have a large head, and certain situations like Dandy Walker, because
Hello, Suhas, we have lost you.
in an hospital position. So
yeah, I think we have lost him.
We have lost Suhas. Okay, Suhas. We need to reconnect. Achha, we have lost him.
He wouldn't be able to hear. Perhaps somebody has to
Now it's
call.
clear. Yes.
Okay. Yes. Okay. Okay, Suhas, you are
Now it's
on.
okay, sir.
Yes.
Create
Yes.
scene.
Yes.
I'm sorry,
Yes.
internet.
Yeah.
I don't know.
Yeah.
I don't know.
Okay. Go on.
What stage did I drop it? I don't know.
Yeah. Go
I don't know.
on.
What stage did I drop out? I don't know. So
Yeah, just one stage, one slide before that.
okay. So
Yes.
yeah. So these are the evidences. There's insufficient evidence to recommend the use of endoscope guidance to routine ventricular catheter placement or ultrasound guidance or computer-assisted electromagnetic. All these have very unclear or unclear evidence. Unclear evidence. So although we use ultrasound for babies, etc., but we do not find navigation, rest of the navigation not useful. Again, when it comes to proximal obstruction, clearly suboptimal position and different levels of obstruction, secondary to secondary improper positioning, etc., is very clear. And certain other very important signs of proximal malfunction is cranial nerve signs, especially in some certain proximal catheters like the in a fourth ventricle, etc. And the next comes the distal obstruction. Now, this distal complications are predisposed when you have an instance where you have previous surgeries, when you have situations where you are treating a post-meningeal hydrocephalus, when you have addition, when you have NEC, neuroenteritis, in an infant with past history of neuroenteritis colitis, and again, another aspect of avoiding a distal obstruction is the mode of insertion of distal. Open is, of course, the safest one. Trocar is a possibility, but trocar has an incidence of direct complication to bowel, and especially when additions are there. And then, of course, the laparoscopic insertion of distal catheters, which can be used when you have additions or a child who has been operated earlier. And then the various receptacles where you put the distal catheter, like the abdomen or cardiac, etc., have very specific set of complications. The cardiac might have different set of complications depending on the position, if it's not properly placed in right atrium, etc., etc. So distal complication depends on previous surgeries, the basic condition, the mode of insertion, and the receptacle. Again, just to mention that laparoscopic is a distal way, a way of putting a distal catheter to avoid distal complications in many of those with complicated abdomen. Infections, I mentioned, is one of the key complications other than the complication which I highlighted until now. The commonest organisms being the MSA, and in neonates and infants, we see gram-negatives, and in immunosuppressants, etc., we might see atypical organisms, including fungal. So our work was basically the certain situations you land up with such a kind of dramatic scan immediately after the first shunt, which might be catastrophe for the child whom we have operated. So if you have to summarize the steps to avoid infections, the only two class 1 evidence that supports complication avoidance secondary to infection is the antibiotic impregnation and antibiotic impregnated sutures. And one with moderate certainty are the protocol bundle, which we mentioned, and the antibiotic prophylaxis staying within 24 hours. Just to mention, since I'm started off with infection, just to mention how a complication of CSF infection is managed. The standard, based on standard evidence, at least certain evidence is clear, although all is of moderate certainty. The use of antibiotic treatment with or without externalization has moderate degree of certainty. Externalization or complete removal, between these two, none has proven to be superior. Again, moderate level of certainty. Use of intrathecal versus intrathecal additional to systemic may be indicated in very specific organisms, in situations where you do not remove the shunt. But at the same time, you need to be clear that use of intrathecal antibiotics can have its own neurotoxic and chemical irritative potential. This is just to summarize this. Of course, these topics are extensive topics. So I wouldn't delve on further, but this is the evidence that is existing for management of complications secondary to infection. So I would conclude my talk by mentioning that the one-size-fits-all approach in children especially will not be is not acceptable. It has to be tailored specifically to the each of the situations. Strictness to all steps of execution is key to avoidance of complications. So you need to anticipate complications, and within your experience and from the experience of others, keep refining. A close follow-up and surveillance is important to avoid complications on follow-up. So at the same time, as when you do it in the youngest and in the youngest, not looking at just the person, looking at the person particularly in his own scenario is more important than just operating and looking at the signs of it. Thank you.
Thank you, Suhas. I think it's a very lucid and concise view of a very vast topic that you have given. It's no easy to, in fact, do a presentation on shunt also as diverse as it is as the shunt procedure itself. So, sir, Dr. Devpujari, can we take the questions that there is? Okay, I think Suhas, can you be online because we'll finish the presentation and take the questions at the end. Yeah.
I think, yeah, Datta, that would be better.
I thought we were taking questions at the end. So
Questions at the end. Yeah. Okay. Okay, we will go on to the next topic. The next topic is on the endoscopic third ventricular stomy, and it will be presented by Dr. Ashish Chu, who is the professor of neurosurgery at D.Y. Patil Medical College in Pune. He requires no introduction, and he has got an extensive experience in ETV and the management. Ashish, can you start your presentation?
Good evening, sir.
Yeah, good evening. You can share your screen.
Sir. So can you see my screen, sir?
Okay. Yes, we can see your screen. Okay, yes.
So good evening, everybody.
Yes.
So I'll be talking upon the complication avoidance in endoscopic third ventricular stomies. So endoscopic third ventricular stomy doesn't need any introduction. It's a technique to treat non-communicating hydrocephalus. Involves making a hole in the floor of the third ventricle to bypass the obstruction of CSF flow. So this is a diagrammatic representation, the scope going through the lateral ventricle, foramen of Monro through the third ventricle and indenting the third ventricle floor. First done by Mixter in 1923. Later, the popularity of ETV waned because of the high mortality and cumbersome instruments, poor magnification. However, in the 80s and 90s, the advances in technology brought together brighter light sources and cameras with improved resolution. And that led to the rediscovery of neuroendoscopy. So the tools generally are the endoscope. Various endoscopes are available in the market, the camera, the holder system. This is the entire set that we need basically, more than what we require. This is a Fogarty catheter, the holder system. These two are the forceps if we need a biopsy, the suction. This is a bimanual bipolar. This is a bipolar electrode, the obturator and the sheet. And this is the scope. We use the LOTA system at our place. So indications, we all are aware of them. Mainly the third ventricle outlet obstruction are the indication. It might be because of the primary aqueductal stenosis, which might be like acquired as well. And the the posterior third ventricle tumors, like the pineal and the tectal tumors, where the biopsy can be combined with the ETV. Then there's the fourth ventricle outlet obstruction, which might be because of the idiopathic or inflammatory stenosis of the foramen of Magendie and Luschka. Posterior fossa tumors, patients with repeated shunt infections, there are uncommon indications like the isolated lateral ventricle with hydrocephalus, the Dandy Walker. There are some case reports of Dandy Walker and slit ventricle syndrome. People are doing it for communicating hydrocephalus. There are some case reports, but we don't prefer to do it for communicating hydrocephalus. As per the indications, as per the success rate, we've seen that the third ventricle outlet obstruction has given the best success rate, almost more than 75%. Then the fourth ventricle outlet obstruction, arachnoid cysts, recurrent shunt infections, malfunction give intermediate success rate, with the least successful rates being in the post-infectious and the post-hemorrhagic categories. Now, there are some favorable features for ETV. Whenever we are selecting a patient, if clinically the if the age at the time of presentation of the patient, the diagnosis of hydrocephalus, or at the time of procedure should be more than 6 months. There should be no history of prior radiation, brain surgery, no history of meningitis, hemorrhage. Radiologically, we need obstructive hydrocephalus. There should be a lack of aqueductal flow, and a thin floor and a downward bulging third ventricle floor is always favorable for ETV. For patient selection, we also have the ETV success score, which includes the age score plus etiology score plus previous shunt score, which gives us the percentage probability of ETV scores. The maximum score being 90%, and patients having a score more than 60 to 70%. We've seen that they have got a favorable ETV result. Then there's the recently introduced the Heidelberg ETV score, which basically in this the mid-sagittal cyst sequences are taken, and we look for the bulging of the lamina terminalis and the third ventricle floor. If the third ventricle floor and the lamina terminalis are bulging, there are high chances that the ETV will be successful. The score ranges from +2 to -2. So this is a setup. We can see the holder system holding the endoscope, the camera systems, the light source attached, the camera trolley, and the irrigation system. When it comes to the irrigation, we can use the normal saline and the ringal-acted solution. However, the ringal-acted is preferable for irrigation, and it should be done at a normal body temperature. Like it should be warmed mildly up to a temperature of 37 degrees Celsius, and use gravity pressure only. This is to avoid any kind of barotrauma. So what is the basic operative technique? Is basically first is to determine the entry point and enter the ventricular system. Finding and entering the foramen of Monro is the second. Once you enter the foramen of Monro, you enter the third ventricle. You inspect the floor of the third ventricle. You perforate the floor of the third ventricle. You enlarge the perforation, and you inspect the prepontine system. These are the basic steps. So targeting there's a freehand method. Basically, the borehole generally we all put in the EVD. It's generally put the borehole is made 1 centimeter in front of the palpated coronal suture at a mid-pupillary line, approximately 2 to 3 centimeters lateral to the midline. And then we aim the endoscope medially towards the medial canthus of the ipsilateral eye. So this is where we generally put in the EVD. However, we generally prefer a borehole with the posterior margin of the borehole just touching the coronal suture. If we have to do a septostomy, we take a bit lateral, a hole which is 1 centimeter lateral to the usual borehole. And if we are planning a aqueductoplasty, or we need to go to the posterior third ventricle, we take a relatively 1.5 centimeter ahead, a borehole which is 1.5 to 2 centimeters ahead. So neuronavigation can also be used for optimal borehole position. It's rarely needed, it's not always needed, but it helps to reduce the traction on the foramen of Monro-related structures, as the fornix and the thalamostriate veins. We generally use it in small ventricles, distorted anatomy, opaque, thickened floor, multiseptate or complicated hydrocephalus, and whenever we need additional procedures like biopsy. So neuronavigation can be used for an optimal borehole position. So you have a target point. The target point is where we have to make the stoma. Then there is the foramen of Monro, and we extend this line, and this helps us on the navigation. This will help us to determine the borehole site. We can use the navigation intraoperative as well. The stellate of the S8 navigation is just 1.2 centimeters short of the tip of the endoscope. So whenever we are lost in the ventricle, what we can do is we can just put in the stellate over here, use the instrument projection to 1.2 centimeters, and that will help us to know where our endoscope is basically. Okay. Right versus left. Universally, the right-sided boreholes are preferred. Rarely you might consider the left-sided boreholes, where the approach on the right side may not be possible, or like in this case, there's the lateral ventricle is dilated. There was a third ventricle dilatation as well, and then this is a functional obstruction. And here there's a right-sided thalamic sol, and we prefer to take a biopsy from the opposite left lateral ventricle. So we used a left-sided borehole in these cases. 2 boreholes might be used in cases of pineal region sols, like so that the structures around the foramen of Monro, there's the fornix and the thalamostriate veins, are not under tension. The anterior borehole is used for the biopsy, and the posterior borehole is used for the ETV. So the steps are basically the head is slightly flexed in a sitting position, the burr hole is made, dura is cut in a cruciate fashion. We first put in a brain needle followed by the endoscope, which will be put in the lateral ventricle, and gradually through the foramen of Monro, we go towards the third ventricle. The correct position for the third ventriculostomy is the center of the so-called hypophysio mammillary triangle. How do you make the burr hole? How do you make the stoma? By a blunt probe, the electrocoagulation or cutting probes, but without using the current. The laser probe and the ultrasonic contact probe. The dilatation of the stoma is done by the Fogarty balloon catheter or the dilator forceps. So this is the presentation of the third ventricle floor, the infundibular recess, the diaphragm celli. Here we can see a transparent floor, which is favorable for an ETV. Here the basilar artery and the mammillary bodies. Once more, after the stoma is made, we should always look for the prepontine space for any other membranes and all. And if there's a liliquous membrane, we have to penetrate a diagrammatic representation. Just a small ETV video. So as soon as you enter the scope, we see the foramen of Monro. Here we see the thalamus, the septal vein, the thalamostriate vein, the choroid plexus. This is forming the venous angle. Here's the fornix. We are entering the Monro. After entering the Monro, we see the mammillary bodies. This is the infundibular recess, the diaphragm cella as in the diagrammatic representation, and the previous picture. And this is the basilar artery. So here is the site for the burr hole, and we make the site for the stoma. The stoma was a bit lateral over here, so we go in the midline. It's always advisable to be in the midline. Lateral stomas can cause damage. Gradual perforation is done. We don't need to use any electrocurrent. Blunt probing should be done. Gradually, as we deepen the stoma, we see that there is a flapping of the floor has started, which is suggestive that, which is predictive of a successful ETV. We start dilating the floor, the stoma. It's gradually dilated with a Fogarty's catheter. The stoma can be dilated by the Fogarty catheter or the ventricular dilator forceps, depending on the surgeon's choice and the conditions, basically. Over here, we are using only the Fogarty catheter in this case. With the gradual dilatation, we see that the stoma has increased in size as well as the flapping. The flapping is becoming more better, and then after the thing is done, we go ahead, check the stoma, check for the basilar artery, and check for any membranes ahead. Once they are not there, without looking too much around, just don't roam around, just come out of it. Fast in, fast out. That's it. You roam around and you might create issues over there. So this is after inspecting the septum pellucidum. This is just a presentation. This was a third ventricular arachnoid cyst, and this is just to show what lies beneath the floor. After removing the arachnoid cyst, this is what we get to see: the pituitary stalk, the pituitary gland, the dorsum scale. Here we see the basilar artery, the fecum artery, and the basilar artery dividing into the posterior communicating arteries. But however, there can be problems, complications can occur because there can be difficulties during ETV. This was a easy ETV because they were favorable anatomy. Now, what are the problems that can arise? That can arise at every step of the ETV. The entry, the foramen of Monro, the third ventricle floor, and the decreased space between while making the fenestration. So we'll see at each of them at a time. So first we see small size ventricles. If when we are doing a small size ventricle ETV, there's a risk that we might not cannulate the ventricles. So whenever we use the navigation at that time, here we see that we are doing the navigation will decide the burr hole. Here, according to that, we decide the burr hole over here. We can see the small ventricles. Followed with that, we put in the needle with the help of the stellate. The tract is dilated with a Nelaton's catheter because it's a small ventricle. We prefer that, and then we put in you can see the CSF egressing out, and then we put in the scope with the sheath. So then there can be a problems while in localizing the foramen of Monro, and if the foramen of Monro size is small, because any problems at the foramen of Monro can lead to problems with that can lead to injury to the thalamostriate or the septal vein, or it can also lead to injury to the fornix, which is which is a part of the Papis circuit, which is responsible for memory. So after entering the lateral ventricle, the foramen of Monro is generally visualized without any problems. Rarely one may have a problem in visualizing. So generally it's an elongated structure anterior-posteriorly. So if we are not reaching the foramen of Monro, we are either anterior to it or posterior to it. Okay. So localizing, if we visualize the choroid plexus, if we enter the foramen ventricle, and if we don't see the foramen of Monro and we see only the choroid plexus, all we have to do is we have to just follow it anteriorly, the choroid plexus. It will take us to the foramen of Monro. This is the direction we have to go in, anteriorly. And if there's ependyma visualized, we can't see any choroid plexus. So probably we are anterior sitting into the frontal horn. At that time, we have to just go posteriorly, and that will take us to the foramen of Monro. Sometimes the Monro might be obstructed. Like this case, there's a post-infective, post-traumatic case. The Monro is obstructed, so we open the Monro by serial dilatation, and we dilate it with it will be later dilated with a Fogarty's and a dilator forceps, and we enter. It has to be done gently so that there is no damage to either of the vessels or we use a smaller Fogarty over here. Generally, you can use a 3, 4, 5 size. So this is a 3-number Fogarty, a green color Fogarty. We are filling it up with NS so that there's no sudden dilatation, and then we increase the size with the dilator forceps so that we can go ahead. That helps us the entry. Now, this is a case of TBM in which the foramen of Monro is just studded with exudates. So we start excising the exudates from the foramen of Monro. We start dissecting them off. The dissection should be blunt. These exudates are generally avascular, and that's the reason probably the antibiotics don't reach over there. Now we dissected bluntly first. We mark the margins of the foramen of Monro, and then we can go and excise it piecemeal. So after we have entered the foramen of Monro, there can be problems in the anatomy of the third ventricle. Like in this case, there's a third ventricle. There's a tumor in the third ventricle. I mean to say, it's a thalamic saw basically, which is indenting the third ventricle and has taken away the entire space. So in this case, after we enter the foramen of Monro, we see that there's a less space. Now in this less space, we can damage the basilar artery as well as we can damage the basilar artery or other structures. So with under navigation guidance, we make the stoma. We see the flapping has started. We start dilating it. And after dilating the stoma, it's after dilating the stoma that we go and take the biopsy. Whenever we are doing an ETV with biopsy, we first prefer to do the ETV. Here we see for any membranes ahead. And once the ETV has been confirmed, we go ahead with the biopsy. The biopsy is taken later. Why? Because if after biopsy there is bleeding, we should we should not have a problem doing the ETV. In this case, as soon as we enter, generally we don't see any blood vessels hanging on in the third ventricles. Over here, we see right at the place where we are going to make a stoma, there is a ependymal vessel loosely starting over there. So we have to stay away from it. That's it. So distorted third ventricle floor anatomy again is another problem, which is the most the difficult part of it is there might be a thickened third ventricle floor, there might be an inflamed third ventricle floor, there might be extremely patulous third ventricle floor and opaque due to exudates. So as soon as we enter the foramen of Monro, here we see, again, this is a case of TBM. The entire thing has been, the problem is over here again is that it is filled with exudates. We excise the exudates, and after excising the exudates, the third ventricle floor is seen, which is very thick, and we cannot make out where the mammillary bodies are, where the dorsum celli is, where the basilar artery is. So again, with the help of the navigation, we try to localize things, and then we probe the area with the electrode, the coagulation electrode, so that we come to know where the dorsum celli is. After removing, we see a thickened floor, completely thickened floor. We probe it so that it should be a gentle probing. We don't push it too much. And then as soon as when we hit the bone over here, we know that we are on the dorsum cellar, and we can see the interventricular recess now ahead. And just behind the dorsum cellar, we open it up. We had taken the help of navigation in this also. And then we dilate the floor. In this case, the problem was that after the surgery, the patient didn't really improve well. So, but it didn't deteriorate as well. So we went ahead with the Cinephase contrast MRI, which helps us to know whether the stoma is functioning. Here we see that the flow void is at the base, at the level of the third ventricle floor. So we waited, and the patient showed delayed improvement. Here we see a patulous floor. The patulous floor has a problem that when we make the stoma, it's sometimes very difficult to put in the Fogarty or the dilator forceps again in the same place because of the patulousness of the floor. So you can see the basilar artery over there, the entire basilar artery. The risk. The two big risks we generally are worried about is one is the bleeding, and secondly is the ETV failure. Now, there can be a decreased space between the basilar artery and the dorsum cellae, and upward herniation of the basilar artery, and it's perforated in the third ventricle floor. A case of fourth ventricle outlet obstruction. Here we see, as soon as we enter, all we see is blood vessels everywhere. The entire area is, the third ventricle floor is filled with the basilar artery, and the posteriorly we can see the foramen open. Initially, we thought we won't go ahead. Then we just tried this thing to make a hole. Slight bleeding, as controlled by electrocautery. We deepen it. There was some there was mild flapping. We dilated the forceps with the dilator forceps. We didn't use the Fogarty over here. Using the Fogarty could be problematic over here. So over here we can use the dilating forceps. That's it. After that, there was some movement, but however, the patient didn't show any improvement. Again, we did a Cinephase contrast MRI, and the Cinephase contrast MRI showed an absence of flow void. So in the same admission, the patient went ahead with we went ahead with a VP shunt. So where to expect these unexpected problems? One is post-infective hydrocephalus, post-hemorrhagic, post-traumatic tuberculous meningitis, fourth ventricular outlet obstruction, and post-operative cases. Sometimes you might have to take a decision to do a VP shunt intraoperatively when the stoma pulses are absent. When we are unable to do a stoma because of because of the distorted third ventricle or the third ventricle floor anatomy, there are severe additions, or sometimes there's severe bleeding, and we might have to place an EVD. For the sake of discussion, an intraoperative ventricular tomography can be done. We generally don't do it. Iohexol 300 mg%, 6 ml in adults, 3 ml in children can be put in the ventricles. A dye washout in less than 1 minute, suggestive of functioning stoma. Dye wash it from the cisterns, taking more than 3 minutes, high chances of failure. Now, after the surgery has been done, this can be a satisfactory ETV and a doubtful ETV. Now, if it's a satisfactory ETV, generally, if the anatomy is favorable, there are good stomal pulsations, and no untoward incidents or complications during surgery, these rightly indicated ETVs will work for sure. In doubtful ETV, generally there's unfavorable anatomy. There might be scarred cisterns, thickened floor. The stoma pulsations might not be very good, and there might be some unprecedented events like an inadvertent bleeding which was controlled. In these cases, we might have to put an OMI or EVD. Daily clinical evaluation is done. If required, a lumbar puncture is done. Lumbar puncture is generally not done in cases which are having posterior fossa sols and ACM. But in rest of the cases, we can just try doing LP so that the pressure gradient might help the stoma. A Cinephase MRI is generally done at the end of first week. If the flow void is present, we wait. If the flow void is absent, we go ahead with a VP shunt. Always go back and check your operative videos. It helps. We've already discussed this. So ventromegaly in patients who have undergone ETV decreases at a much lower rate and to a much less extent than in patients with implanted shunts. So generally, we prefer a CT scan to be done after 6 to 8 weeks to see for decrease in the shunt size. Now, how do you measure? It's basically shunt independence, change in ventricular size, and patency of stoma. These are this is how we measure the outcome. And in the early postoperative period, It is clinical improvement along with a patent stoma that is more important. No predictive value of reduced ventricle size on MRI is there. It's of any importance within first 2 weeks. However, it has importance after the second and third month. Maximum incidence of failures is within the first 2 months. The first month, the failure is because of non-absorption from arachnoid granulation. And in the second month, the failure is because of stomach closure gliosis. Repeat ETV can be done. Whenever we have gone for repeat ETV, these are the things which we have found. One is that there has been no perforation, that's a virgin floor. Next, there was a perforation but occluded by a scar. Then a small pinhole ventriculostomy, incompletely penetrated membranes, and blood clot probably occluding the orifice. ETV rightly indicated, again, re-ETV, 65% patients show an improvement. ETV failure is mainly because of reclosure of the ventricular stoma, narrowing of the stoma, or forming of the membranes. So,
can you conclude?
Important that we come out immediately because there are something known as the blind spots basically. Now, when we are inside, there's no bleeding. But as soon as we come out, probably a scope for the sheet was holding on this bleeding. And as soon as we come out, the bleeding starts again. Now, when there's bleeding, the first thing is elevate the head. Copious warm irrigation of fluid. Copious, like if you have to probably sometimes till the blood clears off, you might have to wait for 15-20 minutes so many times. Intermittent closure of the outflow channel, where there's an inflow channel and an outflow channel in the.
Ashish, can you conclude?
You have to obstruct the outflow channel so that the tamponade creates inside and intermittently leave it. Monopolar and bipolar electrocoagulation can be tried, laser coagulation, mechanical pressure, dry techniques, and external ventricular drain can be used if there's continuous. Dry technique has never been used by us, frankly. We have used it only once when we had operated on a Sega and it had bled. It basically helps in better visualization because the bleeding is so much that the entire CSF is blood stained. You can't see anything. So you remove the entire CSF, push in some air, dilate it, and then you can, in better visualization, you can do electrocoagulation. So the intraoperative complications can be bradycardia. IVH might be because of choroid plexus injury, the basilar artery injury, or even the injury because of the ependymal veins. There can be hypothalamic dysfunction, pneumocephalus, subdural hygromas, CSF leak from the wound, memory dysfunction, and midbrain injury. Delayed complications are seizures and late failure of ETV and sudden deaths. I'll just.
Ashish, can you conclude?
Avoidance of complications.
Hello, Ashish, can you?
Preoperatively, patient selection is important. We have to look at the indications. We have to look at the preoperative neurostatus. A really bad patient with an infective hydrocephalus, we generally don't.
Hello, Ashish, can you hear me or not?
Because the patient won't improve and we really won't understand whether the patient is really
I don't think he can hear you.
Bad neurostatus with a third ventricle outlet obstruction, yet we might try the ETV because the success rate is very high. And we can always use the ETV success score or the Heidelberg score or the pre-op, as I told you, the radiological findings, which can help us to decide whether the patient will respond to ETV. The surgical techniques, we have to always follow the proper steps, go by the books, and principles of sterility are to be maintained to avoid meningitis. Use of navigation can be used, avoid dependency on it, but use it. Use it whenever needed. Use of copious irrigation of RL, proper visualization of anatomical structures is important, adequately dilated stoma, look for the membrane, and fast in, fast out. Don't waste your time over there. Okay.
Ashish, can you conclude?
So, these are the things which again are important. Keep reviewing literature, anatomy and surgery, obviously, but studies. Studies are experiences by other people. Adequate knowledge of the endoscopic system. And don't wander inside the ventricles. Don't hesitate to convert to a VP shunt. Surgical retrospection. Go back to your videos. Develop a team. And have a good mentor with the mentorship programs in the NSI. Now we can always have a good mentor with us. Thank you.
Okay.
This is my thing.
Ashish, can you hear me? Hello? Hello?
I think he is presenting from his phone, Datta.
That is the reason, maybe. Okay. I think let us go to the next. Dr. Naresh Biani is a consultant neurosurgeon at the Wadia Children's Hospital in Mumbai. So, Naresh, are you ready with the presentation?
Yeah.
Okay. He will speak on temporizing measures for hydrocephalus, and somebody was asking about the ventricular subgaleal shunts. So I think that will be answered in his talk. Naresh, please.
Yeah.
Naresh, you have 15 to 20 minutes.
But he has to allow me for sharing the screen.
Yes. You can share the screen, I think. You see the green light?
No, I
Yeah,
can't.
see? Okay. At the bottom, you have a shared screen, no, in green.
Procedure I know, but somebody has to allow from the hosting.
Shubham, just see whether Dr. Chug has. Yeah. I think Ashish is still. He has to exit. Ashish has to exit. 1 minute. I will call Ashish. I am calling Ashish 1 minute because he's not able to listen. Hello, Shubham is there? Okay. I think he has exited. Okay, now you can share.
Okay. Good evening, everybody.
Yeah.
Thank you, MCNS and the organizing team. What I'm going to talk is role of temporizing CSF diversion for hydrocephalus. But what I'm going to talk mainly is the post-hemorrhagic hydrocephalus in a low body weight infant. And that is the same principle that can be applied to other children as well. Okay, next 15-20 minutes. What are the types of procedure we do? Medical, surgical, and from a neurosurgeon point of view, how we can prognosticate. My take-home message is that if you know this slide, that's the take-home message. One is the reservoir, and another is a ventricular lavage where we can decrease the hemosiderin load in the interventional compartment. Diagnosis of a hydrocephalus, rapidly growing, tense antifrontally, splaying of the cranial sutures. Okay. So suppose we have a intraventricular hemorrhage, why we need to treat it, Why? Because when the intraventricular hemorrhage degrades, the hemoglobin, it forms hemosiderin, and hemosiderin is one of the very inflammatory product. It clots the arachnoid villi, it causes inflammation in the ependyma and can cause aqueductal stenosis. Increase in protein content increases the viscosity, and it is again due to inflammation. And premature children, the arachnoid villi are still not formed, so there is a mismatch between the production and the absorption. So now the challenge for us is to decrease the hemosiderin load from the ventricular system ASAP. Okay, the various methods that were used were urokinase, streptokinase, but now modern literature, modern practice, we don't do it. Acetylazodamide and furosemide is again medical and has not found any use. So the goal of treatment is to remove the blood and its product as early as possible, and to decompress the ventricular system to decrease the mass effect and the pressure on the growing brain. These are the two goals of our treatment. Okay, the methods that we have in our armamentum is lumbar puncture, ventric tap, reservoir or a ventricular assist device, ventricular lavage, subgaleal shunts, external ventric drain, and externalized VP shunt. So we go one by one. Serial lumbar puncture is done for a very small child, but if you have a post IVH hydrocephalus, the lumbar CSF is not going to drain the ventricular CSF, and there is a limitation. Maximum that we can drain is up to 10 ml of CSF. That doesn't change any dynamics. Ventricular tap is the easiest one. The benefit is that directly you remove the source from the source, the ventricle, both the pressure and the blood products. It can be done bedside. There is no need to shift the child to OT. And compared to lumbar puncture, more quantity of CSF can be decompressed. The disadvantage or the risk is that it's a very skillful job. Not everybody can do, the resident or the other NICU staff can do it. There is always a risk of new bleeding. There is a risk of introducing a new infection. But the reason why we avoid ventricular tap is that you can't go in the same path multiple times. So if multiple ventricular tap is needed, at the end of it, there is a needle porencephaly that happens, and that adds up to the problem of the hydrocephalus. So we don't want damage to be happening to the growing brain. So now comes reservoir and or ventricular assist device. That is what commonly known in Western literature. Most commonest procedure that we do, and minimum weight probably would be 100,000 grams. Actually, that is enough for the child to the skin and the body can tolerate the thing. So this is how the reservoir looks like. Okay, and this is the position. The only thing that I would comment here is that we have to make a large skin incision, compared to the shunt surgery that we do, and make sure that when the reservoir is sitting in the middle of the same C-shaped incision, because this is the skin that is getting the stress, and multiple needle punches would be done, and we don't want the reservoir to get excoriated. Adequately warmed and made waterproof, so only the exposed area is being kept. Advantage, again, having a reservoir, any resident can do the tapping. So it's a very less skillful neurosurgeon, our neurosurgery fellows, or pediatrician, consultant or resident can do it. There is no risk of an new intracranial bleed because we are not getting into the ventricle, it is just in the subcutaneous. Again, there is no risk of a needle proencephaly because we are again not entering the brain. And if the child is big enough and can be discharged from the NICU, it can be done on an OPD procedure also. So the child need not be admitted as well. Okay, the course of the ventricular reservoir would be that depending upon the blood load and the rate of filling of the anterior fontanelle, usually what required is twice in a week. And our goal is that to clear the CSF ASAP and decrease the pressure on the growing brain. Okay. Now the comes in the picture is a ventricular lavage. Okay, it is feasible and safe option. Idea is to remove the blood products and probably lower the placement of the shunt. Okay, and then there are multiple recommendations, but still we don't have clear evidence, whether it will help. The principle that we use is a geometric dilution where the blood is already into the ventricular system, a new CSF is being formed and a part of the quantity is removed, So as the time passes, the quantity of the CSF from the first thing decreases and then there is a geometric dilution that happens into the ventricular system. I run through few examples. 32-weeker intraventricular bleed, a fetal MRI was done, and then the child was delivered. So here you see there is a clot that has been formed, and there is a gross dilatation of ventricle. Okay, so this is the child. This is the day 3, where the clot is getting organized. Okay, and you see a telltale evidence of a intraventricular hemorrhage and the hemosiderin laden on the ventricular surface. Okay, and then during the procedure when the reservoir was inserted, the ventricular lavage was done, and this is how the CSF was there. And then at the end of the right-hand side bulb, you get this type of CSF, and then the ventricular reservoir is inserted. 38-weeker normal delivery had a convulsion on 3rd day, was put on ventilator, stabilized, and an imaging was done. And here we see there's a thick clot, Most of the children, they succumb to this massive bleed because of the hydrocephalus. And if on conservative management, if the child survives, so the repeat imaging was done. And now we see the blood clot is decreased. We can see the 4th ventricle that has opened up. Here it was all tight, And this is an ideal time to put in the reservoir and do a ventricular lavage. At first instant, if we do the thing, there is whole of the blood clot. So you will not find anything coming out when you are doing a lavage. So this is how a lavage is being done. Okay. With the closed system. What I use is a closed system where the irrigation comes without the pressure on the gravity. And it's a closed system. So less chances of infection, introducing the infection. And you see the color change that happens. Even if the CSF looks good at the procedure, still there would be some blood clot. So this is the reservoir that is placed, and this blood clot slowly gets dissolved, and we have a reservoir that will take care of the dirty CSF and also the raised ICT by intermittent tapping. full term 8-day convulsion, had a massive bleed, was on ventilator. This was the bleed. And the pediatrician neonatologist didn't expected it to survive. So they had a negative counseling. And finally, the family told, okay, you disconnect the ventilator, And the child was disconnected from ventilator, but was thriving, he didn't succumb. That is when a repeat imaging was done. And now you see the clot is getting dissolved, and then the hydrocephalus is cooking up. Now, this is the ideal time to get into the system. Again, this is a 3-way that I use, and this is the 18 number needle that is attached to the ventricular catheter. And this is a closed system, it's very easy and it's quite cheap. 2 IV sets are required. Okay, that is during the procedure. And this is how the dirty CSF goes down. By keeping it low below the thing, the CSF can easily come out of siphon effect, And this was at the end of the procedure. This is the post-op. Drift trial was done, where a combination of ventricular lavage with fibrinolytic therapy and RTPA was randomized trial, and they have found, they did not find actually that there is a decrease in the permanent shunt requirement. In fact, there was a tendency of more secondary hemorrhage, and then intraoperative fibrinolytic agents have been abandoned. EVD in a small child, it's very difficult to manage. And the worst thing is that there's a risk of overdrainage. And of course, when you have a hardware that is coming out, there is a risk of infection. So we don't do it for a small child. Ventricular subgaleal shunt was popularized since 1977. Paris group were the first people who popularized that. And it is almost like a ventricular access device, but instead of a device, you have a subcutaneous collection of CSF. When it was recommended, there were 2 criteria that were proponent. One was that to avoid a foreign body. Okay. But again, when you put in a ventricular subgaleal shunt, you are definitely putting a shunt. So the foreign body is going to be there. Another thing was that in very infected cases, actually, where the antibiotics would not act. So probably ventricular subgaleal shunt is recommended. There was a belief that the CSF would get absorbed from the lymphatics of the scalp. But somebody who is doing that or somebody who has done that, they would know that after some time, there is a epithelialization that happens in the pouch. And see, it just is a glorified pouch actually, where somebody has to drain it, So the risk of CSF leak, infection and delicate skin is always going to be there. Okay, and also we have to prepare the family that there would be a subgaleal collection in the part. And once, if the child requires a VP shunt, then this pocket would disappear. When do we put what is the end result for this? When there is still a hydrocephalus that is monitored clinically, and when the CSF clears and the weight gain is more than 2.8 kilos, that is when we remove the reservoir and we put in a shunt. Okay. Another thing is the infection, that is second commonest indication that we see with the better neonatal care, ventriculitis, and then related to the hydrocephalus. So we have a reservoir and the child continues to take the antibiotic course. When the CSF clears up, that is when that's how it is treated. Take home message. Every IVH has a natural history. Apples are apples, oranges. So just because few IVH have resolved or has a bad prognosis doesn't mean that all the thing have. Prognosis depends upon the aggressive intervention and also the response. Okay, now we are seeing better outcome because of the early diagnosis, ventricular access device, ventricular lavage, safe anesthesia, better NICU and nursing care, and awareness among the neonatologists. Okay, take home message. This is my last slide. Thank you very much.
Thank you, Naresh. I think that was quite a comprehensive overview of how to manage the hydrocephalus till the patient is ready for any VP shunt. I think all 3 talks have been very excellent, and each talk is a very comprehensive talk by itself. But our 3 speakers are beautifully condensed it within the time frame. So we have 2 eminent panelists here. Dr. Dev Pujari requires no introduction. He is the professor and head of Bombay Hospital and Wadia Children's Hospital. and Dr. Jaydev Panchwag is the Chief of Neurosurgery at the Sahyadri Hospitals, Pune. So, sir, Dr. Dev Pujari, can you just summarize all the three talks and with Dr. Suhas, Dr. Ashish, and what Dr. Naresh has said, and then we would like to hear Dr. Jaydev's comments also. Dr. Dev Pujari?
Very difficult task.
Yes, sir.
Datta,
Yeah.
everybody
Yes.
has spoken extensively on all the three technologies. My take on this is very simple. I think there are situations where we work in. If I am working in United States or Europe in a public kind of system, or even if I am working in a public hospital, my discussion with patient is that yes, we want to avoid shunt for the life, and therefore whatever is your success score, you get ETV done first, and if it fails, you will do a shunt. So indication becomes very easy. But if we really want to trouble ourselves and the patient's family while discussing this, it becomes a very, very difficult task to advise ETV to somebody who is less than 3 months of age or where the etiology is not so clear. Similarly, I think the best results we have found in terms of ventricular lavage are that the need for shunt revision becomes less. It has not reduced either the percentage of insertion of shunt or has it reduced any, not only need for the shunt, but other complications. I think we are mainly talking about the fact that these kind of shunts are better, they last longer and they fare better. I think all these things are worth doing because we are dealing with impossible situations and we have to find a solution. Reservoir was very, very difficult to accept during my generation when I started putting reservoirs rather than allowing people to tap through the fontanelle. I was said that I am doing unnecessary surgery, but it has made life very easy for people, including pediatricians who can do it with a sterile technique. And we have managed several patients even as outpatients because it becomes difficult for families to stay there. In terms of shunts, I think it still remains a gold standard. Unfortunately, as Dr. Suhas has very nicely shown, over the period of 10 years, almost 7 out of 10 shunts fail. So when we say gold standard, that is our gold standard. The third point, which I would just like to say as the last point of my talk, is that repeat ETV or secondary third ventriculostomy, as I like to call it, are more successful in situations where primary third ventriculostomy is not successful. And I think that is one area a lot of us people can focus on. Like many of the patients which Dr. Chuk showed, removing granulation from foramen of Monroe or from the third ventricular floor, I would probably back out. I would probably do a shunt, maybe do a septostomy at the most so that I can manage with unilateral shunt. And when the patient clears up, whenever the shunt gets blocked, I may consider it at that time so that these things have already resolved. So I think there are very important messages and I am just adding some of my viewpoints to that. But basically very, very nicely discussed topics. Thank you.
Thank you, sir. I think that were the very wise words regarding the putting the things into perspective. Jaydev, do you have any comments on this things from the younger generation point of view?
Very extensive discussion, definitely. I remember that in 2001, maybe late 1990, I think, I'm sorry, I met Professor Gaab in Vellore, and extremely humble person, and he talked at length about third ventriculostomy. And he really was a very honest person. And he brought out all the possible complications at that time. I remember, since this is, about complication. Having said that, I would like to share our recent experience in last 4 to 5 years in 16 patients of NPH. and the third ventriculostomy has worked in 12 out of 16 patients, and it seems to be working in younger individuals with NPH for some reason, probably because the arachnoid granulations are not completely fired in these people. So I would urge everyone to really give it a consideration, because if it is useful, then all the problem with programmable shunt and then changing the valve parameter, etc., is taken care of. Secondly, phase contrast MRI. There have been recent papers that phase contrast MRI can also be used to gauge CSF flow through the parenchymal part of the shunt, that is brain parenchymal part of the shunt. I would like to ask audience, has anybody, does anybody have a view about it? Because our radiologists have failed, but there are 3 or 4 papers recently. So if someone has, at the end of my, few lines, I would like to have the view. The third point that I wanted to make was during third ventriculostomy, initially I used to, struggle to get to the aqueduct till the time that, and this is for the younger people, and you can, cut the interthalamic adhesion with impunity. That's what one has to remember, because I used to try to struggle to go either above or below the interthalamic adhesion. Sometimes it is very thick in some people and not reach the aqueduct. So that this is a very pointed comment that I want to make. About what Dr. Devpujari said, that distorted third ventricular base is a very, very scary situation. And, I have backed out once or twice, not in an inflammatory hydrocephalus, but in a, baby. And really, you can't make out any details at the base. It was long time back, of course, and we were not using navigation at that point of time. But it is better to back out rather than make a hole at a wrong place. Another point is for, again, younger people, that the Fogarty that is used, what Ashish was talking about, should be the vascular Fogarty, which does not have a jutting end at the end of it. Because, initially when I started, after, speaking and learning from Dr. Gab, at that time I used a hysteroscope, as I remember, in the year 2000. And I used, he specifically told me that he has had experience of basilar artery trauma because initially used a jutting tip. So don't use that Fogarty for anyone who is starting with, third ventriculostomy. And so does anyone have, this is about what I want to say. And does anyone have experience about phase contrast MRI in judging the flow through the shunt? Because that can avoid, like what we do, we take out the abdominal end and see whether shunt is functioning, etc.
Suhas and Ashish can answer that probably.
Ashish,
Suhas, yeah.
No, I don't have that. I don't have. I've not used it.
Ashish?
This parenchymal flow, no, sir, I don't have an idea.
No, because the radiologists here, Ashish, in Pune, they have failed to see it. But there are 3 strong papers. If you go through it, you will find. Anyway, this may become available in future. But on the whole, it was a fantastic discussion. All the facets were covered. And I think the point of, temporary drainage of CSF is extremely important. Of course, there are multiple complications which can occur if excessive drainage is done. I think Naresh was speaking more from the point of view of, premature children, etc. But in adults, the temporary drainage can cause sometimes extreme problems. So that also one has to, remember.
There was one question of TBM having communicating hydrocephalus and what is the failure rate and conversion to a shunt. Suhas, any experience of TBM communicating hydrocephalus?
Yeah, I mean, in this part of the region, the TBM is very less. That's one aspect. But at the same time, TBM as a indication for shunt has always been, because of the high proteins, there has been some aversion towards the initial shunt. Sometimes you do an EVD and then wait for the right timing of shunt, etc. is an option probably. Maybe sir and Dr. Sankla, Dr. Devpujari sir and Dr. Sankla would have more of opinion.
Yes, anybody wants to say? Dr. Sankla?
Suresh, you want to say something?
Yes, sir.
TBM.
Nothing particularly. I think what Suhas said is correct. Absolutely. TBM is something which is a very complex problem. When to do shunt and when not to do shunt is a very big problem. The same thing like ETV, when to do and when not to do. But yes, when the tubercular process is active, I think you try and avoid all the permanent procedures, and rely more on temporizing methods, as Naresh mentioned, in TBM particularly. Once the disease has settled down a little bit, activities are less, then probably you can proceed with the shunt if the hydrocephalus continues to be a problem.
The modified pollutes grading, I think, gives you a very good
Yes,
guideline for that.
It does.
Any sir, Dr. Devpujari? Yeah.
Yes, I have two comments. One was shunt in TBM. So I think the common assumption that protein or acute infection does not allow you to put in a shunt in acute phase. I do not completely agree with this, for two simple reasons: that we have very good papers. I mean, everybody will remember the very first paper came from our institution on TBM shunting by Dr. Singhal and Dr. Bhagwati, and it still holds. I mean, they did actually ventricular atrial shunt at that time, and even then had a very good success and very little in terms of complication. The main reason for that is, I think all of you should probably study individually. We have studied a small subset of patients. Ventricular CSF does not have as much protein as the lumbar CSF protein. And active infection in ventricular CSF in tubercular meningitis alone, unless it is complicated by a secondary infection, is very rare. Therefore, I think there is a scope to put, once a patient is adequately covered with anti-tubercular drugs and steroids, and if you still have raised pressure and progressively dilating ventricles, I would have no hesitation to put it even after 3 or 4 weeks. That is one. Secondly, the ATV success and failure rates. Most of these papers are based on, everybody talks about 3 months patency, 6 months patency, and there is one paper which talks about 18 months they have used in a small subset of 50 patients. I have seen ETV failing after 2 years in one patient. I have seen it failing after 7 years in another patient. Therefore, I think failure of ETV in terms of putting in a shunt is okay, but I don't think we can put a time limit on it.
Thank you very much. I think Dr. Katikar and Dr. Sudhir Ambekar are here. We have to close this session, and I thank all the speakers for their wonderful presentations. Dr. Suhas, thank you very much. Dr. Ashish, thank you. Dr. Naresh, thank you. And also Dr. Devpujari and Dr. Panchwak for their excellent comments. With this, I close this session because we have some time limit. And over to Dr. Katikar and Dr. Sudhir Ambekar.
Yes. I'll invite Dr.
Thank you, Suhas.
Dr. Ambekar to introduce the third newsletter of MCNS.
Hello. Yes, sir. Good evening, all. Thank you very much. Basically, we have the third issue of newsletter come up, and I'm very happy to say that there has been very good response, interesting technical reports on craniostenostosis and Chiari malformation and case reports. We have added, we are continuing with the history section. We have the history of neurosurgery at GMC Nagpur, and followed by something about not neurosurgery, but an important aspect about how to manage finances, especially for younger people who are starting their practice. To end, we have some neurosurgery trivia in the form of crossword and upcoming conferences. I would like to thank all the senior people to have guided in this newsletter, and I request all the members to contribute to the upcoming newsletters. I think Katikar sir is working very hard to maybe think about starting the journal, and let's see how it goes. Sir, do you have anything to say about it?
No, yes, thank you. I think we are going ahead of the time limit. With Dr. Muzumdar for permission, can we conclude the session?
Yes, we can close the session. Thank you.
Sure.
Thank you, all the speakers.
I thank Dr. Muzumdar, Dr. Ambedkar, Dr. Dev Pujari sir, Dr. Panchwag, and all our speakers for their contribution. Thank you so much. Have a good weekend. Thank you.
Thank you. Thank you all. Thank you.